In non-small cell lung cancer, particularly in stage 3 non-small lung cancer, we have very advanced tumours that are very often wrapped around the mediastinum and can very often be close to key structures in the heart. We know that from previous research, structures such as the base of the heart, perhaps also the coronary ostia, the coronary arteries, could be very sensitive parts of the heart to long-term radiation damage. Of course, we have to cure the tumour first, but we also want to minimise the radiation dose that we give to these key structures in the heart. Some of the work that we've been doing is looking to say, what are the other structures that might put you at risk of arrhythmia or late damage? And it's actually quite complicated. We now know that other structures, such as the pulmonary vein, is actually quite sensitive to radiation, and the radiation dose to that actually increases your risk of arrhythmia or long-term cardiac complications in the longer term. So what can we do about it? One is we are using new radiation techniques to better shape the radiation dose around the tumour and away from the normal tissues, though sometimes that's still not possible. The other thing we need to look at is actually optimizing these patients. In other words, making sure all our cardiac risk factors are addressed to make sure that we have as best can use protective medications. And one thing we've done some work in Belfast seems to show that higher dose statins seem to be cardioprotective. And we're beginning to think that actually in the end, this is not a job for us as oncologists alone, it's a job also for a joint clinic alongside cardiology, and there's this increasing interest in having cardiologists involved in managing both the acute and longer term effects of cancer treatments, even outside of radiation.